All right, everyone. So hopefully we had some great discussions during lunch. And so now we would like to welcome our host team from Riley Children's Hospital to share more information about their clinic. So welcome up.
Thank you. All right, thanks everyone. My name is Seethal Jacob. For those that don't know me, I'm the director of our pediatric sickle cell program at Riley, and I co-direct our lifespan sickle cell program with Dr. O'Brien at IU, and Dr. Goubeaux, who's my hematology partner within our sickle cell team and also our hematology section lead. So we're really excited to be able to be here today and talk about our program. My role is to sort of set the stage, to give an overview of what our program is, how we became, and how we sort of initiated the development of this combined sickle cell adolescent clinic for women and girls plus. And Dr. Goubeaux will tell you more about the clinic itself. So I'll start off with our team mission, vision, and dynamic, which you can't see, but I can. So this is actually something that we put together as a team when we were very small and new, and we've continued to update this every year as a group as we grow to make sure that it still speaks to what we believe in and what's very important to us as a team, delivering care to our population of individuals with sickle cell disease. A disclosure that I'm going to give is that this is an imperfect program, right? But it is a program we're very proud of because we built it with a lot of blood, sweat, and tears, like all of you have with your own programs. And even though it's imperfect, we strive for perfection for the sake of our patients every single day. And so we never stop growing, we never stop evaluating what we're doing, and I think that's what makes our program and our team so special. So when I first came to Indiana after fellowship back in 2016, you can do the mental math of how old I am in your heads, we were a very small group, and I actually was recruited to join our health services research group. So I never actually thought I was going to be the director of our sickle cell program, but one thing came to another, and I found myself in this position and realized that we had a lot of work to do. We needed to figure out who our population was. We needed to understand what it was they needed, what they weren't receiving, what their access to care was like, and what care they were or were not accessing. And the first place we started was just sort of understanding the landscape. So this is the state of Indiana, for those of you who think the Midwest is just one big piece of farmland. And you can see that Indianapolis is right in the center. It's that magenta box in the middle. The red box at the very top is Gary, Indiana. It's so very close to Chicago. That's about 3.5 hours from Indianapolis. And the bottom left is Evansville or Newburgh, Indiana, which is at the border of Kentucky and actually part of Illinois. And that's about 3.5 hours from us as well. So our catchment area is very large. It's very rural. And it's also, our urban areas are very medically underserved in general. And that's that map you see sort of, there you go, on the far left. Is a map of sort of the medically underserved areas of Indiana, meaning areas that don't have good primary care, don't have mental health care, don't have dental care. And the map next to it is actually a map of our IU Health network. So Riley Children's Hospital is a freestanding children's hospital, but we are not freewheeling. We report to the health system and are accountable to a very large health system. So this is about 17 or I think 18 now hospitals within our network all over Indiana, but there are some pretty gray pockets there, and those coincide with the medically underserved areas of Indiana, and unfortunately coincide where some of our patients live, which means that it becomes even harder for them to access any care within our health system. And we know that from the own work that our team did. So once we understood the landscape of Indiana and where our patients could potentially come from, we had to understand what were the things preventing them from accessing care and what made care burdensome. And so we learned that most of our families were experiencing multiple barriers. A good percentage of them, about a quarter, were traveling more than an hour to get to us, which increases burden. And several of them had more than one subspecialty provider that they needed to access. Those were not things they were going to be able to access locally. They had to come to us to be able to receive. And that meant that that was being layered with these additional barriers that they were experiencing. And what we realized is all of our patients were experiencing some barriers. Some were experiencing a lot of barriers, and they varied, right? And we needed to be able to understand how we could support them based on the barriers they were or were not experiencing. This, of course, contributed to a lot of psychosocial stress for our families. As psychosocial stress went up, we saw that the odds of hospitalization and missed visits with us increased. And even if they didn't have a lot of psychosocial stress or had a lot of resilience, these families were experiencing a lot of different types of financial difficulties. And those were things that we were not paying attention to, but certainly could prevent you from coming to a clinic visit. If you can't pay for gas and you need to pay your light bill, guess what happens? You're not coming to your sickle cell visit. So in the midst of all of that, we thought back in 2016, we had about 200 or so pediatric patients that we were caring for. And we just started to see this rapid rise over the years, despite not really being ready for that rise. And some of that is just because they realized that there was a sickle cell doc around, that we called ourselves a sickle cell team, which was not happening before. And, the community talks, right? So they start talking to each other and they say, hey, there's somebody new here who says that they take care of sickle cell patients. But a big part of it was also we had a very large immigrant population that was moving into the state. And so these are families where their primary language is not English. They are new to the US and they were seeking care, maybe even being diagnosed with sickle cell disease for the first time within Indiana. And so the age group that we were caring for, the distribution went from actually a very young group to now this group that spanned the spectrum of pediatrics and even a little bit beyond pediatrics. This is before we had Dr. O'Brien. And so we were holding on to them probably a little bit longer than I felt comfortable holding on to them, and certainly longer than most of our team members, and including our inpatient team, felt comfortable holding on to. So how do you care for a growing, underserved, under-resourced population in a 4-hour radius with myself, an APP, a part-time social worker, and a part-time coordinator? Yeah, yeah, I heard the wow part on that. So I'm big on data. I had to think about where I was and what resources we had, and I needed to understand how other places were doing it. And so this was pre-NASAC, but I'm using a NASAC figure to help describe what our patients told us they needed, what team members who were already there said our patients needed, and what other centers were saying were necessary to take care of our patient population. And like I said, we had maybe checked 4 of these boxes at the time. So we tried to make it make sense for us as a team, and we decided that this is what we were striving for our patients. We were striving for convenient, continuous, and co-located care. And so everything we did from that point forward was to try to meet these goals. So how did we do that? So we started with things that were more structurally based or system based. We put in reminder phone calls. We just called our families a week before the visit and said, hey, do you remember that you have a visit? Many did not, and that's okay. We gave them time to be able to move things around and to come. And if they couldn't, we rescheduled them in that moment. We set up a transportation contract with Lyft. The talk from Dr. O'Brien earlier this morning only solidifies the importance of things like that, knowing that Medicaid transportation may be going away in our state. And in the first year, we spent $8,000 in transportation costs. And these are for families where we would try to set up Medicaid transportation first, and it would fail them. Or it just wasn't eligible, right? The child was at school and needed to be picked up from school, and Medicaid won't do that. And then we did things that were incentives. So we created, not me, Dr. Lamott, our team psychologist, created the Sickle Cell Story Club, which is this really cool book giveaway program. And it's focused on books that have diverse characters in multiple languages, right? We choose the primary language of the child and the parent based on age, that have positive messaging for them about identity, about emotions, about sort of the transitions of life, trying to normalize their experience in a world that does not make them feel normal. And our kids love it. They come to clinic and they now start asking if they're getting their book that day. The other thing we did is we established a telemedicine network. So this was the work of my K Award from the NHLBI. And the diamonds on this picture just show you where we started, but we actually deliver telemedicine across the state. Sorry guys, I'm not doing a very good job with this. We actually deliver telemedicine care across the state. So we've been able to develop models that have our patients and families' inputs, and that allow them to have remote physical exams as part of their telemedicine care. So I can do a full physical exam. Dr. Jackson participates in it. Her patients, they get a full physical exam. The only thing we can't do is an abdominal exam, but we teach them that anyways in pediatrics, right? It's reduced a significant amount of burden for our families as a result. Speaking to the continuous care, Dr. O'Brien and I in 2021 developed the Lifespan Sickle Cell Program. We realized that our health system did not understand us being one. We were separate locations, we were separate hospitals, even though we were part of the same system. But we could create this theoretical model where our teams acted as if we were one, even if the care we delivered were in different locations. And these were the pillars that we set forth as our focus as part of this Lifespan program. And we continue to grow and evolve and develop, but one of the first things we did is become members of the National Alliance of Sickle Cell Centers, and we are a recognized center within the Alliance. We co-chair committees within the Alliance, so if anybody's interested, we're happy to talk more about that. We co-administer the State Department of Health Lifespan Sickle Cell Grant with Innovative Hematology and have for the last couple of years. Research-wise, we've expanded our NIH funding. We've established a student summer research program to kind of train the next generation. We're doing some collaborative QI work that Dr. Jackson is leading with the HEAL Network. And then trying to do a lot of work within the community, not just with our CBOs, but with other general hem-onc centers in the state that may not have specialized care or specialists specific to sickle cell disease. So the co-location of care is something that we feel very strongly about and was very much informed by the voices of our patients and families. When I first got there, we actually were already doing some form of co-location. Dr. Chris Jackman, who's a peds neurologist, was doing TCD screens in clinic already. And so one of the metrics that we looked at in the beginning were our TCD screening rates, and those were actually pretty good. Despite everything else, we were able to get kids TCDs because if they came to clinic, they were getting TCDs. And so we used that model to then add pulmonary specialists, That's when we added Dr. Lamont in 2020 to provide mental health support and actually to develop a neurocognitive screening program. Dr. Marcia Hsu helped begin our collaborative women and girls sickle cell clinic. Dr. Goubeaux took over when he came and sort of reinvigorated it. And when Dr. Hsu retired, Laura Erickson has stepped in and has really supported us. We did the same with curative therapies. That was initiated by Dr. Rahim when she was at Riley, and now is run by Dr. Bardal. And obviously we have additional programs that we're hoping to begin. And I'm not going to get into the nitty-gritty of our neurocognitive screening program, but I use it as an example because this is something that just did not exist for our patients 3 years ago. And in fact, when we would refer them to neuropsychology, it would often take a year for them to get in. And by the time that year came around, we had about a 30% show rate of the kids that we referred. So Dr. Lamont, in talking to other experts around the country, put together this screening program. It's done in our clinic. It lasts about an hour and a half. They have a sickle cell visit at the same time, and then allows her to triage concerns. Is this a school-based intervention? Do you need additional testing that maybe will only take another hour and a half at a later point in time? This is the team that helped implement that. These are all faces that our patients already know because they meet with them in different spaces. Maybe? There we go. And allows them to feel comfortable with the folks that they're seeing. This is just like one piece of the data that we have from these 3 years. So in the 3 years that we've had this program, we were able to screen about a third of our population, and that's just Dr. Lamont during neurocognitive screening. You can see that the majority of patients who were referred have been tested, and there's many that are scheduled, so not coming up yet. And you can see this rapid adoption of neurocog screening by our patients and families in those 3 years. So this data has allowed us to now get the buy-in of neuropsychology, and they will be sending one of their neuropsychologists to our clinic twice a month to do screening alongside Dr. Lamont, starting next year. So I use that as an example because that's really sort of where things came with our sickle cell and adolescent clinic. And Dr. Heggie is actually the reason why we even have a combination sickle cell and adolescent clinic. You can see in this picture, Dr. Heggie and Dr. Hsu attended their first LAN meeting in 2015, and in 2018 opened their combined clinic. That same year, Dr. Heggie pulled me along to my first LAN meeting in Dallas, Texas, which was amazing. I had no idea that bleeding meetings were like that because that was not my experience of sickle cell meetings up until that point. But it was an incredible meeting, very, very inspirational. And that same year, we had actually moved our sickle cell clinic to our clinical research center to begin this co-location of care. And so it was very well timed. So coming back from that LAN meeting, we had a lot of conversations. Dr. Hsu actually was very much in support of us trying to initiate something. And we had a very interested, at the time, adolescent medicine fellow, Dr. Leroy Malamed, who's here, who's now a wonderful faculty member at Brown doing this work at her center. And our clinic began. It was grassroots. Dr. Leroy Malamed was seeing patients when she could, and we made it work, right? We just sort of needed to get our patients in the door, and this was a great opportunity to do that. Unfortunately, during COVID and with transitions in positions, the clinic slowed down really to a stop, and so it took Dr. Goubeaux coming to Riley and restarting what we had wanted to do back in 2019, and that has brought us to today's combined program. And the other thing that we really took from Dr. Heggie was, and Dr. Hsu, was the team that they put together for their combination clinic, right? You can see how robust it is, and we were not robust at that time. That took some time to get there, but it stayed with me, and it was part of the conversations we had of who needs to be a part of this team, who needs to be supporting our patients. If we were to do a combination clinic, how do we ensure their access to these resources long term? So going back to this NASAC picture, so by now we know that these are the essential, the optimal, and the adjunct elements of a comprehensive pediatric sickle cell program. And we're doing pretty good, right? It's not perfect. There are things that we're still missing. I'd love a clinical pharmacist, Dr. Weiss. I would love a primary care physician. There are things that I...
First time he's ever heard.
Yeah. You'll hear it again. But we have a genetic counselor, which Dr. Goubeaux will mention further. We have a lot of individuals that really support our patient population, and we have some things that are not in the circle, right? We have a chaplain. That's because our families, that was important to them. We have research staff that are integrated onto our sickle cell team that actually support our lifespan program. So that's how we've been able to expand the clinical trials that we offer for our sickle cell population, not just on the pediatric side, but also on the adult side. And those things matter. Those things matter for our patients. They're exposed to research in a way that they never were prior to this. And then I think it's important to put the faces to the work that's being done. This is our team today. Sorry, Derrick, I had to put you in there.
I was covering the hospital.
Yeah, you were. You were doing important work. This was our state advocacy day this past year, and this is our team. And this is just, I'm very proud of this picture. This is awesome. And these people do a lot of work to support our very large patient population now, and there's still more work to be done, right? It's a reminder that the work doesn't end, and the work should ever evolve. So with that, I will transfer over to Derrick so he can talk more about the program.
All right. Yeah, well, thank you, Seethal. So again, Derrick Goubeaux, I'm one of the hematologists at Riley. Been with Riley about 3 years, and also have the joy most of the time to serve as the section lead for hematology. Talking a little bit about our sickle cell adolescent clinic. Talk a little bit about the initial vision for the clinic, the implementation, go on to some of the gaps and growth and in the future. Having this talk, the vision, again, Seethal kind of highlighted some of it, but we need to go back to when she gave a very similar talk about 4 years ago. This allowed me to bring the greatest movie series ever into this talk. So we're going to hop on our DeLorean, go back to September of 21. It was really highlighted in that talk that Seethal gave is why are we doing this? Who are we doing this for? What are we doing? When and where? I think we look at it, a lot of us in this room, we find these answers quite easily with what we do. That's why we're here, and that's why we serve the population that we do. But it's about working together, this foundation and other organizations, to be able to advance our voice beyond this. Things like this, publications that came out, and this is one that was published with the kind of initial iteration of the adolescent sickle cell team at Riley. Again, looking at why are we doing this? Who are we doing this for? This was a sickle cell provider attitudes, practices, regarding addressing menses, sexual activity, contraception, pregnancy in the female patients. The long and short of it is we want more, we need more, but to do this we need more time, we need more resources, we need more education. Because while we all agreed it needed to be done, there was definitely some variability in who's doing that. Along with the, there we go. Along with the vision, and Seethal shared this, we're going to we're not going to build this without, we don't need to build this on our own, right? We had a roadmap put in place by Dr. Shu and Dr. Hagee, and what was being done from the heavy menstrual bleeding side, this co-located care model, evaluation of underlying hemostatic thrombotic conditions, individualized approach to menstrual suppression support, management for the bleeding symptoms and secondary complications that come about because of those. Again, we don't need to recreate the wheel. How can we take this, build this into something that we can utilize on the sickle cell side? And so this was one of the slides that was shared 4 years ago. This co-located care, a multi-disc team, assessment of the patient outcomes, clinic outcomes, research, quality improvement work, education, and advocacy. Things that, again, I think everybody in this room agrees that we need to best serve the patients and families. Initially started as a half-day clinic once per month. Again, creating this specialty care with limited access previous to this population, improve the provider, family, and patient discussions surrounding reproductive health, perform a breadth of screening assessments, mental health diagnosis screening. Again, this multidisciplinary team in the same clinic. When we look at that a little bit more, certainly from a sickle cell provider standpoint, adolescent medicine provider standpoint, we're there to provide that level of care, but I think really the meat of the group falls below that, and that's not necessarily falls below, but it falls below in the line on the graph at least, and that's with our nurses, the education that they're providing, social work, the support, screening that they're helping us with, psychologists, their involvement, again, the neurocognitive assessments, mental health assessments, management, things like that I am not going to be the primary one, or not that they would want me to be the primary provider managing those things, but reliance on that again, that breadth of expertise that we have within the sickle cell team. Around the same time, this was before my arrival at Riley, and remember this publication coming out, put together by many members in this group, along with the CDC, that let's really highlight where those gaps exist. And this led to me personally pushing for development of a program in my previous institution, and then right around that same time is when the position at Riley opened, and conversations started with Dr. Jacob, and opportunity to come back to this part of the Midwest where I grew up was hard to pass up. Again, we kind of highlighted there was COVID, departure of key members to the team, kind of led the clinic to kind of fizzle out a little bit, but able to re-engage it over the last 2 years. We saw pretty quickly the ability to get our patients, again, in front of these specialists, in front of this crucial aspect in their care pretty quickly. The amount of patients we saw, certainly we can see far more. When we looked at white space, the thing we always love to hear from our leadership, how much white space is on your schedule, there was plenty there to be done. There were plenty there to be filled. Patients not able to get to clinic, no shows, transportation, whatever it might be. Again, meeting a need, but certainly a lot of gaps still exist. We've also learned pretty quickly, as a sickle cell provider, my schedule's filling up quite quickly. We're a few months out with those scheduling, and so when we're trying to squeeze a patient in or put a patient in on that day that we're having that joint clinic, oftentimes my clinic list was already pretty full. Being the newer provider of our group, I took on a lot of the babies, and so I had a lot of 6-month-olds on those adolescent afternoons, and they in time will need Laura, but not quite yet. So how can we adjust that? And that was as simple as, let's go back and readjust your scheduling template and make it in a way that those schedules are, that day it's going to be blocked just for those patients. If those aren't filled within a week or so of that clinic, then those slots would open up and could be filled with patients needing hospital follow-up or more acute visits. We're able to add in additional about 15 to 20% of our patients, not all of those seen within our clinic, but just opening that relationship with adolescent. Some patients just found it easier to see them directly in their adolescent clinic. So again, meeting more patients, but still needing to reach more. We're in the works to expand it even more. We're going to go to 2 half-days a month, again, hoping to open up more slots, more ability to see our patients. We have really been pushing our red cell cure clinic, and the adolescent day is going to overlap with one of the days that we have the dedicated red blood cell cure clinic. So bringing, again, Laura Erickson with adolescent, who also has a wealth of knowledge in fertility, into that same day where she can start to have some of those interactions with patients early in transformative therapy process. She can have that interaction with them much earlier in the process, start those conversations, what going through transplant gene therapy means from a fertility standpoint. Again, bringing her there very early. We have a genetic counselor present for all clinics. The goal when we initially brought genetic counseling into the sickle cell clinic was really targeted at earlier education, patients, families. It really wasn't as much this driven towards adolescent, but certainly a key piece to their work. They're in, like I said, every adolescent joint clinic with us, revisiting the early education they had with patients and families about reproductive risk for that child when they're, again, an infant. Now we can have that conversation again when the child's a little bit older. They're able to comprehend a little bit more, and then also just revisit that for the families, the parents. The other key piece to this clinic, the initial vision really included an opportunity for us to be inclusive for all of our patients, all adolescent and young adults with sickle cell disease, to be able to be seen in this clinic and have access to the adolescent medicine team. Certainly, the focus is on our female population and the sexual reproductive health concerns that they have. But nonetheless, we wanted to make sure that we're reaching all of our patients. There's many pieces, again, that adolescent medicine can bring to our patients beyond what they have been doing for us. And this stood out to me in the conversation that we had as we were looking to expand this, is just adulting in life with X chronic health condition. So adulting with sickle cell disease, what does that mean? Again, be able to have someone that has that sex, drugs, rock and roll talk regularly, very comfortable with giving it, being able to do some of these mental health screenings, things like that, be able to establish with a primary care provider. They have great ties into a teen clinic at the adult hospital across the street from us. So again, how can we continue to meet our patients, our families where they are, and make sure that they're getting the care that they need and deserve. The picture in the bottom right was we always try to do something fun, exciting, interactive with our patients and families, really throughout the year, but specifically in the month of September. And we have a couple Swifties on our team. I share a home with a couple Swifties. And so my wife and daughter and some of the other members of the team took to making a lot of friendship bracelets throughout the month that we as providers have been able to wear, share amongst nurses, other providers throughout the hospital, and then our patients and families. It's been pretty fun. Again, we don't have to do this ourselves, right? We have phenomenal people, many of them, again, in this room that have put together these resources for us, right? It's, what is the best option? What is going to be the best option for XYZ patient? Again, I don't have to do all my research. I can look at the work that Kimmy's done and put this stuff together and be like, hey, someone far smarter than me has already done this for me, so let's just rely on that. And then I think looking at future growth, we're really quite excited. Our adolescent medicine group just recently hired on a pediatric gynecologist. It's always perturbed me that, with a pediatric patient, if there's a pregnancy and they're still pediatric age, that they have to go to an adult provider when that happens. And I certainly understand it, but as we're talking about a patient, a family that, under a very stressful point in their life, I imagine, they're now being forced to leave the team that they know and team that loves them dearly. So hopefully, there might be a potential to change that narrative. At Riley, we have maternal fetal medicine integrated within our clinic or within our hospital. They have their own maternity tower. So again, hopefully some opportunities there for those patients. Obviously, collaborations, we're open, for anybody in this room and beyond. We have a great group, great research support, large population, and again, we're willing to be there, work with you, and collaborate in any way. And as we continue to go through this, continue to ask those 5 simple questions that Seethal posed 4 years ago. Why are we doing this? Who are we doing this for? What are we doing? When and where? Why? Pretty simple. Who? Obviously, the amazing patients and families we care for every day. When are we doing it? Should have been done yesterday. So get to it. This is a couple other pieces. Again, the pictures of things that we've done over the last couple of years. A tree that we have hanging in one of our clinics to highlight kind of comments similar to what we did to start the day about what sickle cell means to them or what they want people to know about sickle cell. And the other ones from this year, the ribbon and being able to tie it on and leave their mark, their name to be shared. Another picture highlighting the amazing group that we have at Riley. Want to take a second, thank everybody for being here, thank the foundation for allowing us at Riley, IU, Innovative Hematology to just showcase what we're doing here in Indiana and the just spectacular care that Hoosiers are receiving. Thank you to the amazing providers in this room. Many of you I probably don't know or really have a close relationship with in any way, but just know your work's mentoring me, mentoring other people, pushing us to be more, do more. So I'll leave it at that. Thank you so much. Dr. Jacob won't talk about this, so I'm going to talk about it again. Fantastic book that her and Dr. Lamont put together. The series itself, a kid's book about phenomenal topics in there, about racism, about equity, about leadership, money management, all those hard topics as a parent, like how do I talk to my kids about these things? This is a great book. My kids have really enjoyed it. Also, when my mom asked me continuously, Derrick, what do you do? Why do you do what you do? This was her birthday present 2 years ago, and it's been great. So.
Questions if anybody has any.
I have a question about the neurocognitive testing. So we just got a psychologist that can do this, and we're trying to assess the best way to go around language barriers. We have on-site dedicated Spanish interpretation on our unit, but other languages are a challenge to have knowledgeable interpreters. How do you guys go around that issue?
It's a great question. So as of now, the child does have to have a certain level of proficiency in English for the tests to be valid. So that's the biggest part of it is these screening tests are really based on English-speaking children, and we cannot say that they would necessarily be valid in other languages. That said, we do have the neuropsychologist that's going to be joining our clinic. She's also fluent in Spanish, and so she will be doing these screens, and we'll be collecting data to see if we think this appropriately assesses what we think it's supposed to assess in our Spanish-speaking patients.
Have you done this via telemedicine?
Neurocognitive screening? We have not. We have talked about it. Probably easier for like the older age group, like the 15 to 16-year-olds. The 3 to 4-year-olds and the 6 to 7-year-olds, we have not quite figured out how to do that because there's a lot more hands-on portions to the testing, and we know that fine motor delays are a real issue in young children with sickle cell. So that part we have not figured out. That said, we're meeting with one of our autism researchers here at IU, actually does a lot of autism testing virtually. And so we're going to see if there is something that we can do to be able to transform this for telemedicine. Yeah, it would be wonderful when we think about access, right? Hey, yeah.
Could you tell us more about your DONE network?
Dr. Jackson. Do you want to talk about that?
So the HEAL network is a pilot that I started with the help of the Department of Ethical Learning, but it was a feasibility study feasibility study to evaluate if a pediatric sickle cell disease learning health network would be beneficial. Interviewed a lot of people who lead learning health networks to gain insight to what makes them successful for chronic illnesses. We're just now at the point now where we're starting our actual pilot, and have invited a few institutions in the Midwest and Northeast, and we're just getting started in our pilot. So it's still very researchy based. But once we get beyond our pilot, we will be expanding, and we'd be happy to have you at that time to participate. But yeah, we're just chose our first quality improvement multi-institution study or QI intervention that we're going to do, focusing on optimal dosing for hydroxyurea. We do have families involved, and they've even shared that, why do we say max tolerated dose? That sounds scary. So in our AIM statement, we changed it to optimal dosing, but we'd be happy to have you as soon as we get past our pilot period. Mm-hmm.
Thanks. Anybody else? Yeah, thank you.
I want to thank Derrick and Seethal. It's really, as someone who's coming from a small to medium program, it's really wonderful to see how like dreams do come true, right? It takes a lot of effort, takes a lot of grit, but it's really nice to see patients getting what they need, which sometimes, I don't know how everyone else feels, sometimes feels impossible when you're providing that care, especially in resource limited